Myself, Dr. Subindra Karki, I will be discussing about the role of imaging in the inflammatory bowel disease in the next coming 15 minutes. So IBD, it is the group of chronic relapsing and inflammatory condition of the gastrointestinal tract, which primarily includes the Crohn's disease and the ulcerative colitis. So it is characterized by abnormal immune response that results in ongoing inflammation, leading to symptoms like abdominal pain, diarrhea, weight loss, and fatigue. And intermediate colitis, it represents about 6% of the inflammatory bowel disease, which has got the features of both Crohn's as well as the ulcerative colitis. So the epidemiology, like it has got more prevalence along the North America and the Europe, but nowadays there is increasing incidence in the developing countries like Nepal, and it affects the young and productive age group. So it is a high healthcare burden. So there are multifactorial etiology like genetic predisposition, immune dysregulation, environmental trigger, and gut microbiota alteration. So basically, Crohn's disease, we all know it can affect any part from mouth to the anus. And there are like the main features are the skip lesions and transmural involvement. Whereas ulcerative colitis, mainly it affects the rectum and it is more continuous. So there are various imaging modalities are being used, like MRE, which has got quite high good contrast resolution, but the major disadvantage is the cost and not available everywhere. And one of the primary clinical use, it is always the first line in young patients, and it can give quite good study about the complications and the perineal study. And it can help in differentiation between the active and the chronic diseases. Whereas IUS, intestinal ultrasound, it is low cost, easily available, you can do on the bedside, and real-time evaluation. Again, the disadvantage is it is operator dependent and limited to some part of the colon. And it can be anyhow used for the screening, follow-up, and point of care assessment, and especially in the pediatric age group. CT, actually we do CT mainly in emergency cases, especially to look for the extra-intestinal evaluation, to look for some complications during the acute stage. And because of its poor lower contrast resolution of the bowel and high radiation exposure, we don't use it for routine purpose. And similarly, small bowel capsule endoscopy, which is very seldom used, but it has got quite good resolution, especially in proximal small bowel, and it can give a detailed mucosal evaluation. However, whenever there is any stricture or signs of obstruction, we don't use it. And it is actually it is used in case of suspected small bowel Crohn's disease and when there is negative ileocolonoscopy. So, why imaging modalities are used? For the diagnosis, it evaluates the transmural and the extraluminal disease, extent of the disease, and guides the treatment, whether it is active inflammatory or the chronic fibrotic stage. And for monitoring, it is used for recognition of the disease flare, and asymptomatic patients with abnormal biochemical parameters may have imminent disease flare. So after excluding the infection, endoscopic or cross-sectional imaging or both should be performed. And to look for the complications, as we know, like fistula, abscess, perforation, etc. So always, conventional radiograph, always we have to start any imaging with the conventional radiograph, especially these are used in first line of imaging modality. Whenever a patient comes with acute severe colitis, suspected perforation and toxic megacolon. And the imaging findings, we all know, these are the like colonic dilatation, thumbprinting, and free intraperitoneal air. And barium studies, although nowadays it is very seldom used because of the lack of availability, we use barium follow-through, per-oral pneumocolon, enterocolysis, etc. And the features we see are the string sign, color butter ulcer, and featureless colon. So here we can see again, this is the case of Crohn's disease, where we can see the stricture and sacculations along the antemesenteric border. And similarly, here we can see on the second image, we can see the cobblestone appearance, which is due to the deep transverse and the longitudinal ulceration. And here, this is the case of ulcerative colitis, the third one. Here it is due to ulcerative colitis, loss of ostration. This is a lead pipe appearance. So advantages are like dynamic evaluation of the whole gastrointestinal tract, It allows the manual mobilization of the bowel during in fluoroscopy evaluation. But again, the disadvantages are the ionizing radiation, and it doesn't give the panoramic view of the abdominal cavity. So intestinal ultrasound, it is the first line tool. It can be done on the bedside, and especially can be used for follow-up and in case of pediatric population. And the imaging features are bowel wall thickening, loss of stratification, non-compressibility, and some extra-intestinal complications like abscess or hepatobiliary complications. And in Doppler, we can see there is, again, increased SMA and IMA blood flow. There is increased PI. There is a reduced resistive index, and we can see there is increase in the portal vein velocity. So again, this is the imaging, ultrasound image, which is showing the circumferential wall thickening with loss of gut signature and increase in the vascularity. This is contrast ultrasound of the bowel. Here we can see increased contrast uptake with rise in the, like this is the time intensity curve, where we can see there is rise in the time intensity curve. CT enterography, we already told, actually it is used for the acute purpose and to look for the complication. And the imaging features, what we see is the segmental involvement, skip lesion, and Coombs sign in the Crohn's disease, continuous disease, symmetric wall thickening, and loss of ostration in case of ulcerative colitis. So cross-sectional imaging is preferred over fluoroscopic studies nowadays to look for the assessment and the complication of the disease. Ileocolonoscopy remains the reference standard for the mucosal disease, but imaging is essential to look for the transmural disease, extraluminal complication, and disease extent beyond the reach of the endoscopy. So again, we can see the first image, here is the case of Crohn's disease with transmural bowel wall thickening with fat stranding. And the next one, we can see the bowel wall thickening, which is involving the descending and the sigmoid colon, along with the thickening of the rectum. So MRI is always the imaging modality of the choice. It has got quite good contrast resolution. There is no ionizing radiation, and it can be preferred for follow-up. And the sign, what we have to see in the IBD is the sign features for active disease. These are bowel wall thickening, T2 mural edema, and the stratification. So the protocol, again, we need bowel distension, T2 weighted imaging, post-contrast sequence, DWI, and the cine images. And for perianal disease, it is the gold standard, and we have to classify, we can classify the fistula as well as the detection of the abscess. So again, this is the T1 weighted post-contrast studies showing enhancement of the mucosa. This is the diffusion and ADC, where we can see diffusion restriction and reduced signal intensity along the ADC images. Again, here we can see the case of Crohn's disease with bowel wall thickening. There is T2 mural edema, and you can see there is a perimural, there is collection, mild collection. And again, this is a diffusion weighted image showing diffusion restriction along the mucosa. So, imaging findings in IBD. IBD means first inflammatory mesentery, where we can see lymphadenopathy, fat changes, and engorged vessels. Bowel wall changes like thickening, stratification, and the permanent structural changes, and various complications, whether it could be luminal or extraluminal. So this is again the pictorial representation of the involvement of the inflammatory bowel disease. So here we can see there is mesenteric fat stranding. This is the CT scan, where the density of the fat, mesenteric fat, is more as compared to the normal mesentery. Again, this is the MRI. Here we can see there is mesenteric fat stranding. Mesenteric fat stranding, it always involves the active disease. Similarly, engorged vasa recta showing Coombs sign, and the lymphadenopathy, again, they indicate the active disease process. So bowel wall thickening, it could be either homogeneous thickening, it could be bilaminar, trilaminar stratification, or we can see the fat halo sign. There is homogeneous, like this is a MRI, axial MRI post-contrast, and the CT scan, which is showing homogeneous wall thickening. Again, stratification. Bilaminar stratification, here there is enhancement of the mucosa, and there is, we can see on the dashed line there, we can see there is some mucosal edema. Again, here we can see on the post-contrast image, we can see the hyper-enhancement of the mucosa. So always, bilaminar stratification, it indicates active disease. And trilaminar stratification, there is hyper-enhancement of the mucosa, there is submucosal edema, and there is mild enhancement of the serosa. Again, these are the signs of the active inflammation. And fat allosine. In a known case of inflammatory bowel disease, if we see fat, submucosal fat like this, these are always the case of chronic disease, not the active disease. But if it is like normally also, if without the known case of IBD, it can be seen, like it is in case of normal bowel. And fibrofatty proliferation, here fibrofatty proliferation is, there is a proliferation of the fat and the fibrous tissues, which is causing displacement of the bowel and the adjacent mesenteric vessels laterally. These are again the sign of chronic disease, not the active disease. So active versus fibrostenotic disease. So active disease, there is submucosal edema, early hyperenhancement, stratification, Coombs sign, mesenteric edema, ulceration, and some complication like abscess, sinuses, and the fistula. And the fibrotic, there will be late and progressive homogeneous wall enhancement, submucosal fatty infiltration, fibrosis, pseudodiabeticum, etc. So there are some mimics. One is IBD versus infectious condition. In infectious condition, the presentation is acute onset, and there is some other signs like ascites, and there is no typical target sign which we see in the IBD. And in case of tuberculosis, one of the DD, which we found more commonly in our part, the segmental involvement is less, and IC involvement is quite common, and we can see multiple necrotic lymph nodes. And malignancy, again, one of the DDs, but for malignancy, again, there is short segment involvement, and there is focal and heterogeneous type of wall thickening. So this is the case of tuberculosis, where we can see multiple necrotic nodes with thickening of the terminal ileum involving the ileocecal bulb. Again, immune therapy-induced colitis is also quite similar to Crohn's disease. So we have to take the history properly. This is actually the case of CA esophagus, where the patient was taking immunotherapy. So proper clinical history is a must. Again, monitoring the disease. So monitoring the disease in IBD is quite important in case of therapeutic response. MR enterography, normally we look for bowel wall thickening, edema, and extraluminal complication. And we look for T2 also mucosal ulceration, wall T2 hyperintensity, which indicate the active disease. Intestinal ultrasound, it is quite valuable for determining the transmural healing. So activity score for MRI, normally we use MR index of activity, where we look for wall thickening, enhancement, edema, and ulceration. And more than 7 is active and more than 11 is severe. But it is more time consuming, so nowadays we use simplified SMRI, where we don't need to use the contrast. So there are various ultrasound scoring, where we look for the bowel wall thickening, color, Doppler weighted formula, etc. And there are various formula which can be validated according to our need. And for MRI, normally we use SMRIA or MRIA. For SMRIA, we give 1 score for wall thickening, 1 for edema, 1 for fat stranding, and 2 for ulcer, which is where we don't need to use contrast, and it's quite simple, and we can use the formula to look for the active disease. We can use MRIA, where we need contrast, and it is more time consuming. So regarding the complication, here we can see permanent structural damage. Here we can see there is loss of normal ostration in case of Crohn's disease, and here we can see lead pipe appearance in ulcerative colitis. Again, here we can see some strictures leading to small bowel obstruction. So these are again some of the complications like toxic megacolon, perforation, and this is one of the severe complications where the patient stopped taking medication, and there are very complicated enterocolic fistulas. So these are again abscess, colorectal cancer. Here we can see there is elevated and thickening of the mucosa along the sigmoid colon, and always whenever there is involvement beyond the hepatic flexure, there is more chance of having malignancy. So these are again primary sclerosing cholangitis, autoimmune pancreatitis, sacroiliitis, which we should always look. Again, so now coming clinical scenario, whenever there is for the assessment of fibrotic versus inflammatory, we always use MRE, contrast ultrasound, and CT interrography in case of urgent. So MRE helps to differentiate between fibrosis and inflammation, and contrast ultrasound, it helps to quantify the vascularity. Again, for the detection of the fistula, abscess, always it is better to perform pelvic MRI. So now coming to the structured reporting, how we should report the inflammatory bowel. First, to look for the sign, whether it is active or inactive, bowel wall thickening, whether there is without parietal stratification, with or without bilaminar stratification. We have to mention whether there is engorged vasa recta, fat halocine, whether present or not, mesenteric fat proliferation, and involvement. We have to always mention whether it is continuous or discontinuous, and segment, which segments are involved, whether esophagus, stomach, duodenum, etc. And regarding the extension, we have to mention what is the length of the lesion, and whether there are any sign of fistula or stenosis, etc. We have to mention. And if there is pneumoperitoneum or collection, we have to always mention in our report. And again, extra luminal complication also we have to always mention. So there is a guideline, ISGAR 2025. This is the latest guideline about the reporting of the Crohn's inflammatory bowel disease. So first line imaging, always MRE is for diagnosis, disease extent, and the activity assessment. CT interrography is reserved only for emergency when MRI is not available. IUS is always acceptable for diagnosis and serial monitoring in expert center. So for stricture, MRE is preferred to differentiate inflammatory versus fibrotic component. Penetrating disease, always cross-sectional imaging, MRE, MRI, and IUS. Just 2 minutes, please. So abscess occlusion should be required before biological therapy initiation. And post-operative recurrence, generally non-invasive monitoring with IUS or MRE, and we can correlate with root gauge score. So now the technical innovation and the future perspectives. So DWI, it is quicker. There is no need of IV contrast needed, and it can analyze the water molecules, etc. So molecular imaging like PET scan, PET MRI with noble tracer, non-invasive quantification assessment, and it visualizes the inflammation at molecular level, and it can differentiate it between inflammatory and fibrotic tissues. And nowadays, AI, always we use AI to enhance the image interpretation. It reduces inter-observer variability. It enables the automatic segmentation and extract quantitative imaging biomarkers. And some recent MR techniques like Cine MRI, MR relaxometry is always used. So finally, integration of the cross-sectional imaging in treat to target strategies, transmural healing as a key treatment goal beyond mucosal healing, multi-center validation of imaging activity scores, AI-enhanced image interpretation for reduced variability, and personalized monitoring strategies based on risk stratification. So, and development of novel imaging biomarkers for inflammation and fibrosis. That's all. Thank you. Yes.